I think as Mary said, we need to work together. And as a data scientist, I'm always wondering what I can do and what are the most appropriate analyses, but also actions across the spectrum that will help combat the public health crisis that emerged and became visible so painfully this year. And it needs to be a joint work. That's why it's very fitting that our opening keynote talk will be by representatives of our state government, because we need government, we need academia, and we need industry partners coming together. In that vein, I invited Drs. Jessie Tenenbaum and Michelle Laws to give us a perspective that will encourage data scientists and help us understand what we should be working on, what should the focus be. They will present a talk entitled Missing Node at Random, Disparities in Public Health and How Data Scientists Can Help. Jessie is the Chief Data Officer in the North Carolina Department of Health and Human Services, also Assistant Professor of Biostatistics and Bioinformatics at Duke. Dr. Michelle Laws is an Assistant Director of Consumer Policy and Community Engagement in North Carolina Division of Mental Health, Developmental Disabilities, and Substance Abuse Services. Jessie and Michelle, we're excited to hear from you.
Thank you so much, Michael. And thanks to Dr. Pancina and the rest of the organizers for inviting us to talk today. And I can remember how to do this. Okay, this is why we practice. So I'm Jessie Tenenbaum, Chief Data Officer for North Carolina's Department of Health and Human Services. And I'm joined today by Dr. Michelle Laws, also at Health and Human Services. And we're really honored to be here to talk about this important problem from the government perspective. So for those who don't know me, as Dr. Pancina mentioned, I'm faculty at Duke, but I'm on leave from Duke for the most part for 2 years, serving as Chief Data Officer for North Carolina's Department of Health and Human Services. Before I joined it, I really didn't know sort of the scope and generally what it does. So NCDHHS is led by Secretary Dr. Mandy Cohen, and it provides in normal times services all across the span, from children's services, low income, food stamps, deaf-blind services. The sort of largest programs in it, Medicaid is the giant gorilla in terms of the amount of money that goes to it. Mental health and substance abuse and public health are also very large programs. So in the government, on March 10th, there was a state of emergency declared in North Carolina. And this kicks into gear at the Emergency Operations Center in Raleigh, where there is literally a situation room. That's the room you see on the right, where a number of people from DHHS go, and this is sort of Operation Central to handle the crisis. This picture was taken a couple months ago now, when we were social distancing, but we weren't yet wearing masks, and there was a larger number there. We have since cut down to additional social distancing and wearing masks. And so what we were doing there, you can imagine there's a lot of different policies that need to be answered, or a number of different questions. So how many cases will we see? When is it going to peak? Will we run out of beds or ICU beds or ventilators? Should we shut down bars and restaurants, schools and businesses? So I think I made some version of this slide a long time ago when the question was, should we shut it down? Now the question is, when can we open it back up? How much PPE is needed and where can we get it from? When can we start things back up again? And what should we start back up first? As you have seen, some of these have begun to be answered, and using a data-driven policy the whole time. And importantly, who will be most impacted? So we are seeing that the impact is really not homogeneous across the state. Different populations are being impacted. Fortunately, we have a lot of data to draw on to make these decisions. I put them not in silos, but in these unique heterogeneous buckets, because they really are in different buckets, and each of them has a different source and very different qualities to it. First, we have cases. This is the North Carolina surveillance data from our epidemiology division. And just recently, I'm excited to say we're getting some of the NCHIE data flowing in there to supplement the data we have. There's also tracing data. Contact tracers have been very active over the last several months, and we've been ramping up, hiring hundreds of people and training them on new software. Testing has been going on and continues to ramp up. Medical surge data is data where a survey goes out daily to 100-something hospitals around the state to inquire about their capacity, their volumes, their availability. And we're moving actually to automating that more so that people won't have to fill out daily surveys, which is very exciting. And then the PPE data, the gowns, the masks, the shoe covers, whatever it is, that is handled as well, and its own unique issues as it's handled by teams that are mostly like North Carolina Department of Public Safety and Emergency Management, who normally handle sandbags for hurricanes and not so much medical equipment. So with all of this data, we can do some modeling. People have seen these curves, I'm sure, saying we needed to flatten it, trying to understand where are we in this curve and where is that dotted line and what is going to be the limiting factor. And we've partnered with different groups in the Triangle in particular with RTI, UNC, Duke. Aaron McKeithen, Duke faculty, who was my predecessor as Chief Data Officer, did a great job coordinating that effort early on, and we still have recurring models that are updated to help inform these decisions. People are probably familiar that models are highly imperfect. It's very similar to weather prediction, where you know where we are now, but as you go over time, it's not necessarily clear what path it's going to take. And even this looks relatively neat. What this kind of map is a model, or is a combination of a lot of different models. So we want to understand what is that specific path going to be, who is it going to hit, who is it going to impact. And what we've seen is that it is not impacting North Carolina population evenly. So this is a snapshot from DHHS's COVID dashboard, and you can see that in the Black or African American population, that population as a part of the state is about 22%, but we're seeing 25% of cases and even more in terms of deaths. 34% of the deaths we're seeing of COVID are in the African American population. Similarly, for the Hispanic population, it's only about 9% of the state, and yet we're seeing 45% of cases in the Hispanic population. So that has been a huge push lately. Almost every meeting I'm in with the secretary, that is a key piece that comes up, is what can we do for our Latinx population? The deaths there are only 8%, so at least it's less about the deaths and more about the cases. So we want to make this better. You can't improve what you can't measure. And as you saw, we're doing pretty well with the distribution of race and ethnicity among COVID cases and deaths. What about the distribution among testing for COVID? This is a bigger challenge because we tend to get data on the positives, so we know who is getting the cases, but up until now, there hasn't been a requirement to report on the negatives. And so the way this was reported was for positives, there's a PDF that people would print out, fill out by hand, fax to the local health department. Someone would get that and key it into a new system. That is just not sustainable, and it's not giving us the information we need. So North Carolina has put together some guidance to try to gather the data that we need to be able to answer these questions. And federal guidance came out this month as well, right in parallel with what we were doing, and mostly matched, so that worked out well. And what this is going to enable is to look across the state and do some geospatial mapping and understand where are the areas of need. This is fake data, but this is representative of a map that we're using. Looking at, we have a lot of different overlays, where the cases are, where our different demographics are, and then we can see where are we testing, where are we missing spots. So here, for example, we have an area of great need, again, fake data, but we don't have good testing there. So we might want to beef up the testing in that situation. So that is sort of the data platform part of this from the data perspective. And for the rest, I will turn it over to Dr. Michelle Laws, who's been doing amazing things in this area. Thank you.
Thank you. I'd like to pick up a little bit and discuss what I think is an important perspective for us to begin as social and behavioral scientists, data scientists, to really begin to drill down on and look at ways that we can use our expertise, our training in terms of data analysis and data collection to help us better understand what's happening behind the scenes, I say, as it relates to health disparities. So what I chose today to talk about in particular as it relates to gaining a better understanding using data to gain a better understanding of health disparities and health equity as we work to develop solutions in regards to policies, programs, and services, as well as medical care and treatment. I chose two areas that I want to just talk about briefly, and one relates to the data collection and some of the barriers. And then another area that I want to leave us thinking about is really looking at how translational science plays a role, specifically making a case for community-based participatory research or community-engaged research, any of the participatory research framings or frameworks, and then also go back to this whole translational perspective and make the case for not just moving from bench to bedside, but from bench to curbside into community. We all know who are in the science space that there are different types of research methodologies and methods, and the two that often we are challenged with developing research programs and studies around are quantitative and qualitative, right? So you all know this. This is not new. And under each type of methodology, there are there are different, I have just lost my screen. I hope not for you all. Please bear with me. I'm so sorry. I don't see my slides.
Yeah, we can see them.
You can see them. Okay, great. I can't. So I'm sort of driving in the dark.
Yeah. They just appeared. If you want to click on slideshow, so they.
Okay, there we go. Thank you. I apologize for that. I'm always freaked out by technology bloops and blunders. So we're very familiar with these two types of research methodologies that are used, and mixed methods, combining them, and so forth. There are assumptions that even though the tools that we use to collect data, the methodologies that we use under these orientations, there are assumptions that apply across them, right? That the data must be honest and accurate. Dr. Klopman mentioned in her open remarks that we must have reliable data. The data also must be relevant, right, to the topic, to the issue, to the area of inquiry, and also rigorous and systematic, guided by research questions and theory. I contend that when we look at the way in which we're oriented as social and behavioral scientists, for me, and for you, the many of you who are watching today as data scientists, and any of our partners and colleagues who practice in different disciplines, that where we are now with COVID-19 and the health disparities that we're seeing, not just in North Carolina, but across the country, that we need to revisit some of the barriers that many of us were trained to look out for and identify, but really look at them in the context of where we are today. And so one is this whole mistrust of the healthcare systems by historically marginalized populations, very real experiences, rooted in experiences and historical practices that many of the historically marginalized populations have experienced. And for North Carolina and for the work that we're doing at DHHS, we identify historically marginalized populations as African American or Black, Latinx, or Hispanic or Latino, American, Indian, or Native American populations, immigrant populations, and refugee populations. And so those are the core H&Ps that we're doing a lot of work around to address the impact or the disparate impact of COVID. And so we as scientists and social and behavioral, whatever field that you practice in, data scientists in particular for today, it's important that we understand how mistrust of healthcare systems can impact the quality of the data that we're collecting. And I'll talk a little bit more about that. It can impact the reliability of it, not from the scientific perspective of validity and reliability, but also from the perspective of, if people aren't trusting the data collectors, then the quality of the data, it can impact the quality of the data that they're receiving. Maybe not getting enough of the variables or data that we actually need to make informed decisions that can help improve health outcomes and service systems. The scientists and subject mismatches and differences, I think play a role in that, right? Our objectives or your objectives as, now I'm on the policy side of things and program and services side of things. So our objectives vary or are different from that of our research subjects. So the objectives and goals and expectations of data scientists may be to work on an amazing, groundbreaking research project that gets them published in a peer-reviewed journal, right? That's a very different objective and goal and expectation of the research participants or subjects, right? And so we need to make sure that we're factoring in and that we come level setting into the space of where we're collecting data and who we're collecting it from, level setting, being very clear on what the objectives and the goals and expectations are. I contend that because there's been this mismatch along the way, that the one has received the rewards and the benefits and has met their objectives and goals at the expense of the other. And oftentimes the expense of the other means the communities that we're serving, the communities that we are researching, and the research subjects that we have included in our research projects and proposals or plans. And then this lack of cultural understanding and awareness goes in line again with this notion of mistrust and some of the experiences that historically marginalized populations have experienced. But it's also on the side of us not doing the work, right? Us being the social scientists, the data scientists, the research scientists, not doing the work to really fully understand the cultural nuances of the populations. And again, I'm talking about within the context of health disparity, within the population, specifically the historically marginalized populations that I mentioned, not doing the work to really fully develop cultural humility and understanding what those nuances are that can impact health behavior and also health outcome. And then currently, Jessie mentioned the way in which we are being intentional about really making sure that we're collecting the right data. But the reality is, when you look at federal and state and local level data collection systems, data repositories, there's no standardized data on racial and ethnic differences. They are inconsistent. So some municipalities may be collecting race and ethnicity data. Other municipalities, for different reasons, some of the reasons I've heard is, well, we've got such a small percentage or proportion of the population that is that represents historically marginalized population X. We know that if we put this data out there, then it could result in some undue stigma. People will know who we're talking about. They could be stigmatized and discriminated against. And so there are different reasons why systems are not, and municipalities, local, state, federal government systems are not collecting data in a certain way, but and systematically and standardized. But it's extremely important in order for us to be able to disentangle the factors associated with health disparities, for us to be able to see and to understand what it is we're trying to measure, and not simply collect data, put them into a nice statistical model and crank out some, outcome without understanding the context and the people and the culture. This requires, I know that having this kind of precision in our data collection, precision in our data analysis, and understanding, doing the hard work of understanding the cultural context and relevance, it's time consuming, and it requires careful consideration, of lots of resources, cost, time, staff, benefits, and even wondering, questions and appraising the utility of the work. For an individual, it's important for us to standardize. It's important for us to make sure that systems are talking to each other. It's important to make sure that data scientists have done their work up front to understand some of the nuances that may be impacting the data. And for research scientists to also understand that, because as an individual, representing a historically marginalized population in particular, we see that they're sharing information with so many different sources. So think about a person that is on Medicaid. they, have access to healthcare and health and treatment, but they are also most likely to be involved in other types of health and human services, right? Or receiving other types of health and human services. So to have to share your information with all of these systems and all of these, for a good reason, right? To improve your health outcome, to address a particular health issue. So for good reason, but to have to give this information over and over again. So electronic health records are extremely important, but making sure that these systems are talking to each other, and that there's, and of course, recognizing all of the constraints in terms of privacy and security, HIPAA violations, and so forth. But as an individual, being involved and having to provide data, important data, sometimes can be very exhausting because of all the systems. And so as I sort of wind us down, I just want to make this case for making sure that the work that we're doing, that we understand that as you as data scientists, just probably, confirming what you already know and just encouraging you to make sure that you apply the lens of translational and participatory researchers and scientists. Understanding that it's all relative, right? It's important to make sure that we understand and we consider not just our objectives and goals as research scientists, as data scientists, that it's not just our objectives and goals that matter, but that we consider the goals and objectives and the utility and perception of the consumers, the patients, the research subjects. It's also important that we are very precise and that we understand that we are, and we're being guided by theory, but also being guided by research questions that can help us to better improve health outcomes and service delivery systems. So saying with that said, one of my favorite Albert Einstein quotes I learned when I was in graduate school at VCU in the School of Medicine, working on my PhD there, getting my PhD from there, one of my professors had said, not everything that can be counted counts, and not everything that counts can be counted, and attributed to Albert Einstein. Now, I could never find the original source from Albert Einstein, but it's a well-known and quoted. And I think that's important for us, and it's important especially for you as data scientists to understand that some of the things that we may want to throw into our model, some of the things that we may want to research and look at may not translate and is not relevant to helping us really dig deep, take deep dives to understand, and I say drill down to the next level to really understand what's beneath the surface that's leading to some of the disparate outcomes and impacts that we're seeing. We can't improve what we can't measure. And is what we're measuring actually indicators of improvement? That we should always be asking the question and using the research participants and subjects to ask the question, what else do we not know? What else matters other than the research questions that we've come up with? And then again, why is this important? Why is it important to really look beneath the surface, look at cultural nuances, look at community nuances and differences? Is because when we don't do it right, when we aren't really drilling down and hitting at the root causes of health disparities and disparate health outcomes, we see these kinds of trends. We see African Americans and Hispanic and Latino and Latinx communities shouldering a disproportionate share of the health disparities, burden, and health outcomes across indicators, whether it's cases or deaths. At DHHS, we are really intentionally drilling down and taking deep dives into looking at trying to understand what some of the factors are and engaging historically marginalized populations in a variety of ways. There is a large work group that's doing this work that's spread across the other work groups that are working on our COVID response. And that includes holding community stakeholder meetings and listening sessions, developing and disseminating health promotion and education material that's linguistically competent and culturally humility-based, and doing some research on the research science side of things. And that is all I have. I will turn it over back to you.
Thank you very much, Jessie and Michelle. I think a lot of food for thought. I think lots of questions and lots of conversations to follow up. We're running out of time. I want to just ask one quick question, because I think, Michelle, your words were very powerful and resonating about the models. And we data scientists pride ourselves in the fancy mathematics and ever more complex methodology, and missing the social context makes all that work problematic and questionable. At the same time, you talk about trust as being a barrier that we, the scientific community, research community, are not trusted. So what can we do to understand better the social context that's so needed to create valuable models in a situation where there isn't trust to begin with, right? If we start going out in the community in prose and there isn't trust, we may not hear what we need to learn. So what would be the advice you would give us as the first steps in learning and deepening our understanding of the social context?
Thank you for that question, Dr. Pensina. I think, again, I'm a proponent of the community-based participatory research model. Now, I know that it is time consuming and it takes a lot of time to really on the front end engage research subjects. I'm a proponent of most participatory research models. And so I think trust is based is built as you're developing relationships with the research subjects, right? And so long before you are ready to start collecting data, have some conversations with the populations that you are conducting that are involved in your research. And I think that goes a long way with sort of, one, it shifts the way things are currently done for the most part. And it shows communities, especially historically marginalized populations, that you're not just interested in them as data, as data points, right, or as resources of data, but you really do want them to help you to better understand the research problem that you're addressing, and go in with a sense of humility, right? That we are data scientists from a wonderful university. State of the art, top high achievers and so forth. But we also, there's a lot we don't know. And I think communities like historically marginalized communities appreciate that kind of humility and you coming to them and saying, before we start this, does this look right? And usually it's somewhere in between once it's gotten started that conversation is held.
Thank you. No, that's so important. I think humility and advanced planning, I think that's a very powerful message for our community. Thank you so much, and I look forward to more discussions, because I think we need to work more closely together. Thank you, Jessie and Michelle.